I think one of the things that happen with the gestational diabetes is if you see you've got three separate groups here. People who got pre-existing type 1 diabetes who become pregnant. So people with pre-existing type 2 diabetes who become pregnant, or people who get a new diagnosis of type 2 diabetes during pregnancy, or people who develop diabetes related to pregnancy. So for the people who develop diabetes related to pregnancy, the standard way of detecting that is by doing an oral glucose tolerance test. So for which they have to go to a center where the test is done. So they have to stay there for the specified period for the test, so usually 2 hours more. And then they need to come kind of frequent contact with the people who do those tests. So one of the ways that people looked at is that, so can we avoid doing these oral glucose tolerance tests? So can we use other parameters so to make a diagnosis of gestational diabetes, like HbA1c or fasting glucose, and then identifying that. So most of the worldwide organization, be it in Canada, be it in Australia, be it in UK or otherwise, so they came up with some modified guidelines for diagnosing gestational diabetes based on HbA1c or fasting glucose. To give an example, so people have got HbA1c between 41 and 47, which is impaired glucose tolerance test normally, impaired glucose, impaired dysglycemia in the sense. So they are now grouped under having gestational diabetes, so they basically must be treated at. So people with slightly lower HbA1c, then they may need to rely on the fasting glucose. So the guidelines vary slightly differently from different parts of the world. So, but the overarching theme there is to say how we can avoid oral glucose tolerance tests to use other parameters which minimize the contact with or minimize the risk of exposure. And in terms of people with established diagnosis and their management, then people have moved on to virtual consultations where people share their glucose recordings with their healthcare professional and using telephone or video consultations, so to give them the advice that is needed. Or people have moved to a multidisciplinary team model, so where at one visit, so you will get inputs from different specialists like obstetricians, midwives, the diabetes team, so that the number of visits are minimized in that sense. Or using technology in the sense that people are using a wearable glucose like flash glucose monitors or continuous glucose monitors, so which record glucose levels all the time, and those can be shared remotely with the healthcare professional who can then review the data and then give more value-added input to this individual remotely rather than making them to come to the hospital for visits. Yeah, I think those redefining the diagnosis and then using technology to minimize the face-to-face interaction. So, and by doing so, reducing the risk of exposure in these people.